This is the recording for Chapter 13, Neurocognitive Disorders. There are several different types of neurocognitive disorders, and we will look at all of those. The neurocognitive disorders are ones where there is a significant decrease in cognition or memory, and it changes the person's level of functioning. First, we're going to talk about what delirium is. So delirium can happen to anyone. Um, Delirium is a mental state where there is a change in the level of consciousness and cognition. There could be short-term confusion, disorientation, excitement, hallucinations, illusions. This can happen for a variety of different reasons. It can happen in elderly, and it can also happen in young people. Um, so these are the symptoms of delirium, and they develop over a fairly rapid period of time. Difficulty sustaining shifting attention, distractibility, disorganized thinking, speech that is irrelevant, incoherent, inability to reason, uh, behavior that is not goal directive, and being disorientated to time and place. Other symptoms include misinterpretation of the environment, including those illusions and hallucinations. If you remember, illusions is when something is there but you misinterpret what it is. Sleep-wake cycle problems. Um, the person may be agitated, or they may be very stuporous, or like in a semi-coma. And their emotions may change quickly from irritability to depression to apathy to anger. Autonomic manifestations you may see with delirium: tachycardia, sweating, flushed face, dilated pupils, elevated blood pressure. So this usually starts quickly. It is usually due to maybe a systemic illness. It may be a head injury. It might be a seizure. And usually this is a brief illness, 3 to 7 days. Once you eliminate the underlying cause, then the patient will go back to the normal cognitive place that they were. Um, Someone with who has cognitive impairment in the first place, it may be more difficult to see this. This happens a lot in elderly. They um, Nursing home or the family report that they've had a big increase in their confusion and irritability, and think there's dementia is getting worse. But in nursing home patients, the most common reason for this is a urinary tract infection. Um, the elderly have less clinical symptoms that we would expect to see, or are unable to relate those to their caregivers. And so it may seem like their confusion is worse, but it's an underlying disorder that once they have treatment for this underlying disorder, then they're going to go back to their usual state of health. So people who are most likely to get delirium are ones who have a serious medical, surgical, or neurological condition. Um, People who are over the age of 65 are at high risk. Medical conditions can include infections, febrile illnesses, metabolic disorders, head trauma, seizures, migraines, brain abscess, stroke, electrolyte imbalance, and there are many others. So there's also substance abuse induced delirium caused by intoxication or withdrawal from substances. This can be illicit drugs like marijuana, alcohol, other illicit drugs, methamphetamines. Um, Withdrawal from these can also cause symptoms. Could be medication induced. Mentions the anticholinergics, the antihypertensive, the steroids cause behavior changes. Um, the drug Chantix that people take to stop smoking can cause a delirium. Toxins can cause this. Um, Lead, mercury, arsenic, carbon monoxide. So the definition of neurocognitive disorder is a condition where the cognitive function in a particular area of brain, which have to do with thinking, reasoning, memory, learning, and speaking, are impaired. Neurocognitive disorder can be classified as minor or major. Um, It is very important to pick up when either someone has a mild cognitive impairment because that's when we can do some intervention to either prevent or slow the progression of the disorder. There are more things that are being shown to be effective that we can do um, that are alternative treatments rather than medications. Um, None of the medications we have at this point in time are able to stop or cure the disorder, but they do slow down some progression. But there are also lifestyle things that can be done. So, major cognitive disorder is when there is a very noticeable um, decrease in the ability to think and reason, remember, and that's when we call it dementia. And the dementias can be primary or secondary. Primary are ones that are caused by some brain disease, not directly related to any other organic disorder. Secondary are neurocognitive disorders that are caused or related to another disease or condition. It could be cerebral trauma, arterial sclerosis in the brain, HIV disease in the brain. Symptoms impairment in abstract thinking, judgment, impulse control. Social conduct rules may be disregarded. Behavior may change, may be uninhibited and inappropriate, where you see someone doing something that if, had they in their previous state of health would never have said or done things. Personal appearance and hygiene can be neglected. Language can be affected or it may not be. Um, Sometimes people don't speak at all, have aphasia. Um, the ability to communicate will change as the disease progresses. Personality change is also very common, and the example, a person who is very socially active may become isolated. A neat person may become very untidy. People who had trusting relationships with the person may all of a sudden be fearful and paranoid about this person. So, reversible neurocognitive disorder, only a small percentage of cases fit this, and it's not really, if this happens, it's not really neurocognitive disorder as we usually think about it. So these are things like brain tumors, depression, side effects of medications, metabolic or nutritional problems. Um, this is um, once the problem is taken care of, it goes away. It's kind of like with the delirium. Once the underlying effect is taken care of, then the problem goes away. Um, so it's not exactly a neurocognitive disorder, but they call it reversible neurocognitive disorder. As the disease progresses, you may see aphasia, inability to speak, apraxia, inability to carry out motor activities, and even though you have motor function, um, changes in mood, outbursts, inability to take care of themselves and their personal needs, wandering, um, and then incontinence. Wandering is very problematic. Um, every year we see some elderly person who has wandered away from a nursing home or home and they get lost. If the weather is bad, they also don't understand how to dress for the weather, and so it can be disastrous consequences for them. Most cognitive disorders are Alzheimer's disorders. Between 60 and 80% of all cases are caused by Alzheimer's. There are stages in Alzheimer's. Stage one is there's no apparent symptoms. Um, there are changes that are starting to happen in the brain, but there's no decline in memory at that point. Stage two is very mild. Person may start to lose things or forget names. Short-term memories problems are fairly common. The person is aware that there has been a change and they may become very depressed and anxious, which will make the symptoms worse. They may go to using lists or structured routines to compensate for the memory loss. Usually people don't notice. They have seen it, but other people aren't noticing yet, and it does not interfere with their ability to live or work independently. Mild cognitive disorder, this is when work performance is affected. It becomes noticeable to others. They may get lost when they're driving, unable to concentrate, difficulty recalling names, words, and becomes noticeable to people, family, close associates. Stage four is moderate cognitive decline. This is the place where you start forgetting major events in your personal history, such as your child's birthday, um, unable to perform tasks like shopping, cooking, manage your own finances, and may not be able to understand what the current events of the world are. The person may deny that they have a problem and try to cover up by confabulation, which is creating imaginary events to fill in memory gaps. Depression and social withdrawal are very common at this stage, and the person may need some assistance to be safe. Stage five, um, people start losing their ability to perform activities of daily living, require assistance to manage these tasks. They may forget addresses, phone numbers, names, disorientated to place or time, but at this point they still maintain knowledge about themselves. Frustration, withdrawal, and self-absorption are very common. Stage six is severe. This is a place where people may not be able to know the name of their spouse, may think their child is their spouse or their spouse is their child. disorientating to surroundings, and the person may be unable to recall what day it is, what season, what year. They are unable to manage without assistance. Delusions become apparent. Um, Maybe believing that they have to go to work even though they no longer have a job. Urinary and fecal incontinence are common. Sleeping becomes a problem. They may wander, may be agitated, aggression's possible. Symptoms seems to worsen in the evening and late afternoon, which is called sundowning, and they have more problems with communication. This is the point where institutional care might be required. Stage 7 is very severe decline. Um, Patient is unable to recognize family members, commonly bedfast and aphasic, um, immobile. So neurocognitive disorders are differentiated by their etiology, although they share a common symptom presentation. Alzheimer's disease is characterized by the syndrome of symptoms identified as mild or major in the 7 steps that we just talked about. Um, Refinement of this diagnostic criteria now enables clinicians to use CT scan or MRI to find degenerative pathology in the brain, which you may see atrophy, widened cortical sulci, and enlarged cerebral ventricles. So, hypotheses about what causes this. They include neurotransmitter alterations. Um, in the brain of patients with Alzheimer's, the enzyme that is required to produce acetylcholine is reduced. This decrease in acetylcholine reduces the amount of neurotransmitters that is released to the cells in the cortex and the hippocampus, resulting in disruption of the cognitive processes. The plaques and tangles, overabundance of these structures appears in the brain. It's thought that these contribute to the destruction and death of neurons, which leads to memory failure, personality changes, and other features of the disease. Head trauma. People who have had a history of head trauma have an increased risk for Alzheimer's disorder. This head trauma may happen years before they ever develop um, dementia. Genetic factors, there are some familial patterns with Alzheimer's disorders. Um, there is now testing that can be done to see one um, if your possibility of getting this disorder prior to actually having the symptoms if someone else in your family has, and uses usually in early onset dementia. Okay, in vascular neurocognitive disorders, there is significant cerebral vascular disease, impaired blood flow in the brain, and then intelligence decreases. It differs from Alzheimer's that it has a more abrupt onset and runs a very variable course. Progression usually occurs in steps rather than a gradual deterioration. Causes of vascular neurocognitive disorder are directly related to interruptions in blood flow to the brain. Symptoms result because of death of nerve cells in the regions that don't get enough blood flow. Um, Hypertension can damage the lining of blood vessels, can cause small hemorrhaging in the brain. Uh, may cause things called mini strokes, cerebral emboli, and cerebral thrombosis, or strokes can also that occur in a strategic place of your brain can cause neurocognitive disorder. Another type is frontotemporal neurocognitive disorders. It was called Pick's disease in the past. Occurs because there is shrinkage of the frontal and the temporal anterior lobes of the brain. Um, Cause is unknown, but they believe that there is a genetic factor um, in play here. Clinical patterns, behavioral and personality changes, and language and speech problems. Traumatic brain injury may also cause a neurocognitive disorder. Um, Caused by an impact to the head or other mechanisms of rapid movement or displacing the brain within the skull, causing one or more of the following: loss of consciousness, post-traumatic amnesia, disorientation, confusion, or other neurological signs. Amnesia is the most common following a head trauma. There also may be confusion, changes in speech, vision, and personality. The person may be emotionally labile. Um, they may have very sudden changes in behavior and mood, which can be, along with the impulsivity, maybe cause damage to themselves or others. So, Lewy body disease, similar to Alzheimer, but progresses much more rapidly. There's an appearance of Lewy bodies in the cerebral cortex and the brainstem. It's progressive, um, irreversible, and may go through 25% of the cases of neurocognitive disorder. There are visual hallucinations and Parkinsonian features. Depression and delusions are common. This is the disorder that Robin Williams was diagnosed with prior to his death by suicide. You may see neurocognitive disorder also with Parkinson's disease. As many as 75% of patients with Parkinson's will have a dementia. In this disease, there is a loss of nerve cells in the substantia nigra, and the dopamine activity is diminished and causes involuntary muscle movement, slowness, and rigidity. And tremor in the upper extremities is characteristic. Brain infections of HIV can also cause a neurocognitive disorder. HIV-1 infection with that can cause a syndrome called HIV-1 associative cognitive motor complex. There's also an HIV-1 disorder. So, in the early stages of this disorder, there may be some neuropsychiatric symptoms, some changes in a person's normal physiological, psychological presentation. Severe cognitive changes and changes in behavior and psychosis are not uncommon in the later stages of this disease. Substance disorder, substance-induced neurocognitive disorder. It can be caused by substance reactions, overuse, or abuse. Symptoms are consistent with neurocognitive disorder and persist beyond what you would expect for intoxication and acute withdrawal. This can be alcohol, sedatives, hypnotics, inhalants, um, anticholinergic um, drugs, and toxins such as lead or mercury can cause this. Huntington's disease is a genetic disease. Um, Damages occur in the basal ganglia and the cerebral cortex. Um, Symptoms usually start about between age 30 to 50, and the patient declines in a profound state of cognitive impairment and ataxia or muscle incoordination. Prion diseases can also cause neurocognitive disorder. Um, Jakob Crutchfield or bovine spongiform encephalopathy or mad cow disease. Uh, Symptoms usually occur between ages 40 to 60. Um, Rapid pro- progression from diagnosis to death within 2 years. Um, there may be some genetic component to this also, and the clinical presentation looks like um, mild to moderate neurocognitive disorder, involuntary movements, muscle rigidity, and ataxia. This slide just gives you a list of diseases that may cause a neurocognitive disorder, um, and there's a whole list of them here. So, patient history, it's very important we get a good history from these patients. We need to know what their symptoms are, how their cognitive changes are happening, um, their thinking process, um, can they problem solve, what age have these changes started, um, they have language difficulties, are they orientated, and is their social behavior appropriate? We need to know if they used drugs, medication, alcohol in the past and what those were, if they were possibly exposed to some type of toxin, and we need a good patient and family history of illness. We need to look for various diseases that can cause confusion, loss of memory, and behavioral changes. I think in depression, I talked about that with the elderly. We need to rule out depression before we decide that somebody has a neurocognitive disorder, because the symptoms of depression can kind of mimic that. Physical assessment, we need to look at their neurological exam, um, look at their muscle strength, their reflexes, language skills, coordination. We also, again, want to look at depression and make sure that the person is not having issues with depression and it's causing these instead. So we want to do lab results. We want to look for blood and urine tests. We want to look for infections, liver and kidney problems, diabetes or hypoglycemia, any imbalance in the electrolytes, any metabolic or endocrine disorders, presence of toxic substances, and looking for nutritional deficiencies, the vitamins and such. Other things that might be done is an electroencephalogram, a CT scan, a PET scan, MRI. If we think it might be an infectious cause, with a lumbar puncture might be necessary, and then maybe a PET scan to look for amyloid changes in the brain, those um, beta plaques and tau tangles in the brain. So we want to make sure things that we want to look at is their risk for trauma, their thought processes, their memory, sensory perception, risk for other directed violence because of confusion, impaired verbal communication, self-care deficit. Um, early, they may have a low self-esteem because of when they are still looking to hide this disease from others and grieving. What we want is the patient not to been physically injured, not to harm self or others, maintain reality orientation to the best of their capacity, um, be able to discuss positive aspects of their life, and participate with daily living activities as they are able to, with assistance that is needed. So we want to um, try to maintain their thought process as much as we can. Um, we want to make sure the environment is as safe as possible. We might need to adjust the furniture, make sure that they don't have obstacles in their way. If the person's agitated, we may need to make sure that this environment is not stimulating. If the person wanders, we want to make sure that they are um, in a place where they can wander but is safe and they can't wander away when we're not watching. Um, we want the person to maintain reality orientation. So we want to do things that will help them remember clocks, calendars, signs, pictures of family can help, and um, making bringing things from home so that wherever they're living, if they are not at home, that it seems more comfortable to them. So people with impaired verbal communication, make sure that the patient is able to let us know what they need and we can fulfill what they need. We want to keep the interventions calm and reassuring, using nonverbal gestures and maintaining consistency. Um, Patients who are not able to perform their self care or activities of daily living need assistance, guidance, help with um, doing as much as they can do for themselves, um, but looking at their ability and then anticipating any needs that they may have. So, patient and family education, this is hugely important. Um, we want to teach about the disease, what the possible causes are, what to expect, and what the symptoms are. Important for the patient in the early stages to understand, and for the family to understand that the person will not get better, that this is a progressive illness, um, and what they need to look for. And the patient in the early stages needs to know what they can expect. Things for the family. How do they make sure that the patient is safe? Maintaining reality orientation. Um, how do they assist with daily living activities? Nutritional information. Feeding may be a problem, especially a wanderer. They may need finger food so they can eat while they wander. Um, Difficult behaviors and how to deal with those. Administrating medications as needed, and how to handle hygiene and toileting. Support systems, financial assistance if needed, legal assistance, caregiver support groups, respite care, home health care. Um, Caregiver support groups are very helpful because this is a 24/7 responsibility if these people are taking care of their loved one at home. And even if they are in a care facility, there's still responsibilities that the family has. Um, Legal assistance, while the patient is still able, it's very important for them to get this education about what to expect from this disease, and so that they can make some decisions. If they don't have a healthcare power of attorney, a financial power of attorney, and a living will, they need to do that now while they're still able to, so that they can make their wishes known while they're still able to. And that's one of the big things with education. And if we catch this disease early enough, we can help with the concern they have with, um, in the beginning, with the forgetfulness and worrying about that, um, depression that leads to, because of these symptoms. We can give them information about what the disease is, which is not going to be good news, but then they can get some of these things together, let their family know what they want when they're unable to make those decisions for themselves. Evaluating. We want to make sure that there's no injury. Can we maintain orientation? Can they fill their basic needs? And do caregivers have information that they need on the progression of the illness? Many families will ask the question, well, when are they going to get better? And it's hard for families to understand that this is not going to get better. So, education for nurses. Patient-centered care, maintaining safety, interdisciplinary teams for caring for the patient, evidence-based practices, quality improvement, and using informatics to help with us care for our patients. For delirium treatments, medical treatments, need to know what the underlying cause is, um, need to have a patient monitor with the person to help them with reorientation, low stimulus level, possibly if they need it, low dose antipsychotics to relieve their agitation, benzodiazepines when there is due to substance withdrawal. Um, Need to look at fluid and electrolyte status, oxygenation, diabetes, and blood sugar issues. Um, some physicians prefer not to put patients with delirium on medications because additional agents may only compound the problem. But if the person has psychosis with agitation and aggression, they may require some type of chemical or mechanical restraint for their personal safety. Um, so that is a something to consider whether you're going to use medication or restraint if someone is aggressive with others. For neurocognitive disorder, medications can be used. Um, there are some medications that have been shown to enhance the functioning in mild to moderate Alzheimer's disease. Um, they do not cure anything, but they may slow the um, progression for a time. They're not going to cure anything. It's important for the family to understand that. So Namenda is one that has been approved for treatment of moderate to severe Alzheimer's disease and has been shown, clinical trials say that Namenda can improve the cognitive function and the ability to perform ADLs in some patients with moderate to severe Alzheimer's disease, although it still isn't going to cure the problem. Um, so pharmaceutical agents for aggression, hallucination, thought disturbances, and wandering. The medicine on this um, slide are all antipsychotic medications. They are block box warning on all of these atypical antipsychotics that there is increased risk of death in elderly patients with psychotic behaviors due to a neurocognitive disorder. So that's always something that needs to be thought about. Depression. So even if the person does have a neurocognitive disorder, an antidepressant may be used, um, possibly to make sure that it's not related to depression. Um, but because depression is also happening in these people who have neurocognitive disorders, so that's a possibility too. So um, SSRIs are used first because they have less of side effects. Tricyclics aren't um, recommended because of the anticholinergic and cardiac effects of that. Trazodone is not a really good choice for depression, but it works really well for insomnia. And dope, dopam, dopaminergic agents. So um, methylphenidate being one of those can help with severe apathy. Um, Anti-anxiety medications may be helpful, but shouldn't be used routinely. Um, Benzodiazepines are the least toxic and most effective. Valium, Librium, Xanax, Ativan. Um, Ativan and Xerax are actually preferred because they have a shorter half-life. Medications for sleep. Um, some physicians also use the sedative hypnotic medications in addition to the trazodone. Um, Paradoxical agitation can happen in elderly patients, so it's possible that these medications that are supposed to help them sleep may make them agitated, or the sedation can move over to the daytime hours also and be a problem. So there's a few more here, pharmaceutical agents that they have listed. Um, Non-benzodiazepines and benzodiazepines. Again, daytime sedation may be a problem. Barbiturates should not be used.